fibers, so it was demarcated by the so as you can see, it is away from the tumor. Then the next will be neuronavigation, identifying the medial lateral superior and inferior border of the tumor. Then the next will be similar to the other principles of microsurgery. The tumor will be resected as safe as maximal as possible. Then at the end, they use the fluorescent colors as you can. If a remnant tumor is visible or if the study considers that there is a remnant tumor similar to this, so the research will be continued. Considered to be safe in young 30 years old patient because it is completely balanced and on imaging I had left 68 tumors which were tablet vestibular schwannoma. So in this case the position is similar to what we have for the position of the and then neuromonitoring was utilized. So the neuromonitoring involves cranial nerve 5 and cranial nerve 7, 8, and also using the endotracheal rods. There is small endotracheal which can be used for monitoring of the cranial nerve or the vagus nerves. So all the slow cranial nerves are we have monitored. So the fascial nerve monitoring was put on the around the right or the around the nose and the other sort of technique. So intraoperatively, just the resection was smooth and they have also the neuronavigation to mark the borders. And then the surgery was entirely intracapsular. There wasn't any single cauterization of the capsule outside the capsule. Everything was intracapsular, and even there was no significant manipulation of the tumors. So finally, yes, a prostatarization was made, and there was the whole capsule was remnant. It was left untouched. Then postoperatively, the patient's hearing and fascial nerve was preserved, and also control was made. There was many remnants. So maybe what we can learn from this is just as long as we have the monitoring, we can decrease the rates of postoperative fascial nerve deficit. We can also, we know some of the tumors are very huge and it is also difficult to preserve hearing, but with monitoring this, we can preserve at least fascial nerves. If possible also, hearing can be preserved. And also the monitor, how we present on that, the monitoring is also really affordable. This patient was also a female patient with huge scalous tumor involving the right jugular foramen with extension to the CP angle. So the magnification was utilized to mark the borders and also to identify the course of the transverse sinus and the sigmoid sinus and also the junctions. So similar to our setup, the position was similar, and next intraoperatively it was developed serially, and then intraoperative frozen section was taken. It becomes plasmacytoma. So the resection was safe. It was not totally removed, and the intraoperative frozen section was denied to the plasmacytoma. So what I want to raise is that intraoperative frozen section we use in Korea, and maybe if it's possible also it would be good to use in Tikur Anbessa, at least to diagnose and to limit our extent of resections intraoperatively. Years back, and then subsequently he experienced very severe axial and lower extremity pain. It was in fact had to do all the possible medications with multidisciplinary approaches, and then subsequently spinal cord stimulation was considered, and then once the advice and consultation is performed, the next trial will be just having an stimulation trials. So the stimulation trial, it involves just percutaneous insertion of a rod, and it will be with the patient for like 4 to 5 days. Then its effect will be assessed objectively and subjectively. So objectively, if the pain is decreased by at least 50% of the previous one, based on the visual analog scores, it should be considered as successful. So once it is successful, the next will be doing the definitive stimulation. This definitive stimulation could be performed either percutaneously with a wear as a tip of, with an electrode as a tip of wear, or it could be performed just as open laminectomy and the placement of the electrodes. So they use this positioning table, and here, as you can see, the spine surgeon will perform the laminectomy, and if you can see, the surgeon who is on the right side is stimulating. So monitoring will be placed over the abdomen and around the lower possible level of the spinal cord injuries, and so the neurofunctional unit, the neurofunctional team will prepare the battery and the electrodes. So once the stimulation is successful, so the next will be just placement of the batteries and the electrodes. So the electrodes, as you can see, this one is the battery. It is called the IP. So this is the electrode. With, as you can see, this is the electrode. This is called paddle electrode. So this will be placed as the area which is the most possible site of the pain symptom which is elicited by the patient and the intraoperative stimulations. So this paddle electrode will be secured to the nearby tissues, and then preoperatively there will be preparation of coquettes around the lower abdomen or the flanks, and it will be put inside. Then the patient will, we know, just before that the patient will have to relieve the symptoms, which was the pain, and then subsequently it will be modulated, so it will stay. And the outcome is also relatively good, even textbook mention. The other procedure we saw was minimal spine procedures. Among them we have seen olive and the oblique lumbar and fusion, and the lateral, the transforaminal lumbar interval fusion. So as you can see, this is OR, which is 360-degree arm. So the image will be registered with CT scan, MRI, and a new X-ray with high quality X-ray will be obtained. So the image will be assimilated with the preoperative using a navigation. So usually they use microscope. So you can see this is the neuronavigation camera, if you can see. So they are just preparing for the next neuronavigation to identify the level, and if screw placements also considered to do percutaneous fixations. So they utilize endoscopic removal of the disc space. They just approach through the oblique, and they will the trajectory is approach the CS muscle, and then they will identify the neurovascular structure, the vascular structures medially in the psoas muscle anteriorly and laterally. So once they are in the disc space, it will be removed as microdiscectomy principle, and once it is removed, it will be prepared, and this one has different size of this materials, which can be very important for widening and maintaining of the disc spaces for possible preparation of the intercody implants. So once the implant is performed, the next will be if there is a need for posterior fusion
they will navigate, as you can see. So this is a neuro navigation. You don't have to worry about the trajectory or the angles. The projection will be in front, and then you're directly, for instance. So this is the pedicle finder. So the pedicle finder has its own camera, which is associated with the neural navigation. So whenever the pedicle finder, as we can just hit down or just rotate, and it will tell you the angle you will see. One, the depth of interest. The other one is the trajectory, whether it is medialized, lateralized, and also it is depth of interest. So once this form, so the other case we saw was coccydynia. So this one is usually a rare case. We don't see this kind of cases. If we see, yes, it is common related in females. And we experienced this. She was Ethiopian patient. She went to Aster CMI from here, from Addis. And this patient, she experienced severe coccydynia, and there she was waiting for 1 month to be operated because the spine surgeon was not, he was in doubt whether the conservative management was tried or not. So she was given injection, and she was then waited for 1 month to see the response for the injections. Then after 1 month, the response was not significant, and then coccydyectomy was done. If you can see, this was the fracture. This is the fracture. It was small, and yes, coccydyectomy was done, and the rest of the sacrum was smoothened to just avoid subsequent pain eliciting. Otherwise, the patient was good. She was tolerating the surgery. Yes, the reason why I put here is just we were told that once a patient is sent from here there, they will just rush the surgery. But still, sometimes they try they stick to the principles. If something is in doubt, just they stick to the principle usually. So the other important thing we saw is this is an orthopedic bandage. So here, personally, I have never ever seen to use this bandage as a cotton pad. This material. So even professor prefers this one. It is very smooth. So it will be prepared by the nurses. Then it will make things simple and effective with our resources. The radiology technicians also do similarly. Everyone does his or her jobs according to his professional disciplines. There was no even we have never ever seen that the surgeon asking the anesthesia why the blood pressure is rising or something. If the anesthesia knows how to, if it is intraction, he knows the level of the blood pressure. If it is spine, he knows the level of the beats. If it is, for instance, there was one patient of diffuse OPD, and we were just observing what will happen, what will be the BP. If there wasn't any communication between the surgeon and the anesthesia, they know that it is high in the cervical region, and the BP should be maintained high, and it was maintained like that. So everything, multidisciplinary team is very important, and also if it is possible, some of the like the neuro monitoring is it will have dramatic changes in our setup if it can be affordable, because Mahal will present some of them are relatively fairly affordable. So the other one is everything there is a system. Just they run the system. So that one was also very important. So as end, I would like to thank our department and and also the other stockholders like the lab and also Dr. Dami and Professor for allowing us to see this one as observership. So hopefully we expect this to continue with like this and also to add more residents. So at least to see where we are and what we think for the next. So thank you very much.
Good evening, everyone. So, I will continue with my observation. As you can see, this is a traditional flower pattern which is made in India. So they made it on the floor. So that we call it rangoli. It has its own representation and reason why the Indians are doing it. If you are interested, you can read about it. And it has a very interesting reason why they are doing it. So, first of all, I would like to thank Professor Ravi, Dr. Dak and his team, Dr. Abed, so Dr. Thomas, Dr. Kabul, Dr. Jordanus, Dr. Sakaza, to communicate for the financial aid and also Jacob for his willingness to support this program. So, this is the airport of Bangalore. I have a difficulty of naming the airport because it's difficult. Doesn't you remember the name? It's very difficult. Anyways, it has its own documentary on National Geography. They built it with the bamboo, and now I know Indians are very good architects. And so if you go there, you can see multiple, technologically advancements there. So, but my interest is not only the technological advancement, but the teamwork and how the system works is amazing. So if you find one crazy rich Abesha here, you can buy whatever Aster Hospital has. But the difficulty will be finding the physicians, the experts. It will need like 10, 20 years. So as we all work in the academic institute, so investing on human resource is the most important thing, what I saw there. So because they have everything, not in technology wise, but when it comes to the experts. So it's a very interesting observation I made. So let me go to some interesting facts or some interesting information you may want to know. So this is most of the surgeries, especially the spine, the functional one, patients, they don't actually take any muscle relaxant to monitor for the neural monitoring. So as you can see, this is a surface EEG. So it has what we call the PIs. It has its own graph, as you can see. So it will tell you the depth of the anesthesia. So the anesthesiologist, So in our setup, we always shock with the patient awake, but they actually follow the brain activity and maintain the brain activity between, as you can see, 42 and 97, so that they can tell that the patient is in deep anesthesia or if the patient is awake. So this is important because the neurophysiologist actually has a communication with the anesthesia, the neuroanesthesiologist during, for example, for MEP, they want the patient more to be awake. For neuromonitoring, they want the patient to be awake, so that the neural response can be traced easily. So this is use and throw surface EEG to monitor the depth of the anesthesia. The other thing, we have everything here. The other important thing we saw is the neuromonitoring and intraoperative navigation. So for a single spine procedure, this is for OLIF procedure, also for any cranial procedure, for most cranial procedure, for functional surgeries. This is how they put all the neuromonitorings. This is the actually use and throw, but they reuse it after sterilizing it, so they will connect those pins through this port with a single PC. So if I thought it is a big instrument to monitor, but it's like a box which has communication with these cables. But the most important thing is you need the experts who can follow it intraoperatively. So let me show you one video. So this is the legend showed you the patient with vestibular schwannoma. So the intraoperatively, they actually communicate with the video. So this is another video. So this is how, this is for the spinal cord stimulation. So the surgeon has a probe which has a so this is the box. As you can see, this is the box, the PC over it, so that they can use the PC monitor. So the surgeon then show you the probe, so stimulate the nerve roots, and they will see the response. So over the nerve root. So as you can see, there are some neuronal change. So you will tell the exact root or the exact nerve which is stimulated, so that they can know where they are, or they can know where they should put the spinal cord stimulating. So the most important thing I saw here is, so the surgeon tends to have the urge that the patient is getting a response, but the guy on the neuromonitoring, it has his own decision. He said this is a proper response. He said this is an artifact. So they thought it had a response, but he said this is not a response. So yes, you can have this one, but having a guy with that much confidence to tell you this is the proper response for you is the most important thing. So one important observation I made is that one. So they actually so this is also for the vestibular schwannoma. So we all know that here the brainstem evoked potential should be monitored. So they put the facial nerve monitor for cranial nerve 5, also for the lower cranial nerve, so the endotracheal tube. For it is like a wireless earphone kind of thing, so that they can follow all the waves from 1 up to 5, so that intraoperatively for cranial nerve 8, they can tell that whether there is a major manipulation or not. So the surgeon communicates. I think this is on our review, so the neurocritical, the neuroanesthesiologist actually follow this one. So the surgeon will stimulate and they will follow the arm, endoscope, or intraoperatively. So, yes, you can do it like easily, but to be safe and to be more of practical, so they do everything what they have for the patient, and this is interesting. But to say that it is very difficult even to position our patient when you see this one. It will take like 5 minutes to do this one. Everyone has its own responsibility. There is O-arm guy, there is a C-arm guy, there is a one who actually manages the neuro monitoring, there is also neuro anesthesia. So how the system works is amazing there. So one important thing, maybe you can in detail ask professor because he is a functional surgeon. But the first case we saw there is the temporal lobectomy, where people have amygdalectomy. So they use standard, as you can see, to localize the craniotomy and also to look for the temporal resection posteriorly. They use the neuronavigation, especially on the medial part of the temporal lobectomy to avoid the ascending and descending tracts, also to avoid the midbrain. So you can use the neuronavigation. So this is also an MRI integrated with the neuromonitoring. So by standard, they do the temporal lobectomy. So one interesting thing is this one. So intraoperatively, the EEG, that means the seizure activity. At the baseline, they use intraoperative grids so that they can trace where is the seizure. So postoperatively, they also monitor the EEG, that means the seizure spikes. So they have, as you can see here on down, there is the EEG tracing. So they have a neurologist intraoperatively so that he can tell whether that seizure activity is there or not. So the most important, the neurologist actually involves in the surgery and also make a decision intraoperatively. So because this patient was not dominant, it was not a dominant hemisphere, so they actually go beyond the 6 centimeter and the seizure activity subsides. And preoperatively, this patient also had a deep electrode so that they know whether the seizure focus. This patient has 2 lesions, one frontal and temporal. So they inject that one. So you can see intraoperatively when the seizure activity stops. So this is the most interesting things we saw. And the neurologists they are so pro to surgery, especially for the mesial temporal sclerosis. So intraoperatively, they rely on each other, the neuroanesthesia, the neurologist, and also the neurosurgeon. So the other thing he wants to know is the deep brain stimulation. We were lucky to see a deep brain stimulation. So this is a patient. She was worked up and she was came to the OR for bilateral subthalamic nucleus deep brain stimulation. So as you can see, the patient in the recovery, they put a frame on her. She had a block so that there is no pain. So actually the neuroanesthesiologist follow each step, and also the functional neurosurgeon, and also there is a specialized nurse to do this one. So after they put the frame, they took the patient to the CT scan, and they integrate the CT scan image and the patient baseline MRI so that they can plan this one. So this is the first, I think, female functional neurosurgeon in India. She was trained under Professor Ravi. So that is Dr. Guru. He is also a fellow of Professor Ravi. Now he's doing his fellowship under Professor. So after the image are integrated, so they will plan the trajectory where to put the electrode. So this is a planning phase. So the most important thing we saw is they took, much of the time during planning. After that, they will fix the trajectory, the angle and everything of the subthalamic nucleus, and everything will be recorded, and this recording will taken to the OR. So the patient put on Mayfield with the frame. As you can see, the patient is awake. So this is pre-draping. As you can see, there is a CR, there is a patient warmer, there is a neuro anesthesiologist, there is also radiologist technologist, there is also nurses, also neurologists, and functional surgeons. So this is the neurologist intraoperatively. He assesses the baseline, the neurological condition of the patient, and intraoperatively he continuously monitors the patient neurological condition. So the patient is awake, so that he can communicate with him. So let me show you one or two interesting videos here. So as you can see, they already put the frame, they already planned the trajectory. Now they are putting the electrode through the black hole of the plant. So this is the functional neurosurgeon, the fellow. This is also a nurse. He's amazing nurse. Actually, he knows too much when I see on the functional part. So she is putting the electrode. So previously they told us they actually make with their hands. Now they use a motorized system, so that motor actually advance the electrode to the exact millimeter. So they just put this one, and after this there are another person who actually manipulates the depth of the electrode. So as you can see, this is the functional neurosurgeon and the guy from Medtronics. One interesting thing so the pharmaceutical companies, when they brought the implants, they will bring their own technicians. So for example, if you want to put a pedicle screw, a guy from, let's say it's a Medtronics pedicle screw from a Medtronics came scribing to the OR, he actually manages the materials. Still the same here. In our setup, the patients buy the screws and they will bring intraoperatively. If something's happened, no one is responsible. But here, so the pharmaceutical companies who actually brought these instruments are in the OR, so that they can manage the complication or they can bring a bailout option if something goes wrong. So all these things are overseen by professor. You will see it later. So as you can see, the neurologist will. This is the. So the depth of the electrode will be fine-tuned by, so the electrode tip has some sensors so that they can see whether that is in the thalamus, whether that is in the subcortical nucleus, whether that. So the position of the electrode exactly determined by the specific pattern, wave pattern, saying sounds. If there is no speaker here, but if you can hear it, there is a specific wave pattern so that you can tell the exact location of the electrode. So this is what they drive. The depth of the electrode will be driven by the remote control. So for every rotation, the electrode will advance 1 millimeter. So they will follow the wave pattern there. So you can actually ask professor on the details how to manipulate. So after some time, they will secure the exact location of the electrode. So this is the electrode placement. After this, maybe one video. So during this time, the neurologist will assess the patient. the language, whether she's the tone, the weakness, the extraocular movements, you know, from the science side, whether medial or lateral, all this can be determined by the patient's clinical. So they will communicate continuously during the procedure. So after they make sure that the patient is okay, after they determine which stimulation is important for this patient, they will take ACR intraoperatively. So as you can see, those are the electrodes in the brain. So immediately post-operatively, before they remove the frame, they took the patient to the OR. So they will check whether the electrode are in place. So as you can see, it is in exact place. So this is all about the deep brain stimulation. So it's too much things happens there. So we try to capture the most important thing, but the most important thing we saw there is, yes, everything, the electronics, every materials, but teamwork and leadership is the most important thing. As you can see here, the spine surgeon operating for in spine cases, the endovascular surgeon operates the vascular cases, and all the cases, especially for functional work, is led by Professor Rabi. Now he's, I think, the director of all the Aster Neurosurgery departments. So another important thing, work hard and play hard. What we saw. So they actually work hard when they have the time. They will get together and they actually play hard. This is Bangalore. You already saw the image. It's a beautiful city. They call it what we call is one of the most beautiful city in India, and also green city. I have maybe some concerns from my observations. There is too much use and throw materials there. So this is my feedback. So I wish in the hospital everyone has its own bottle so that they can use it. But as you can see, like hundreds or thousands of those bottles will be used daily in the hospital. So it is a use and throw. Everything is use and throw. So the motorbike and the tuk-tuk, I don't think that has a solution now. So this is the other thing for our country. I wish for India, even I wish those kind of things has a control over it. So I think you can do something about the use and throw thing. And intraoperatively, this is a private hospital, they can afford it. But sometimes, as you can see, to grow the skin, they use 3 staples. So those staples use and throw, and it's very expensive. So if you stick to the basics, and if we can manage the most important thing, for example, for the CPA tumors, not having the neural navigation and everything, but having the intraoperative neural monitoring is the most important. So you can see everything is fancy, but you can avoid some of it and you can take some of it. So you can close the skin with the silk, just forget about the staples, but you can take something from their setup. Another maybe warning, if any one of you heading to India, there is no coffee there. So this is like after 1 minute of communication with the guy, to make it strong, we actually use the Google Translating to make it a strong coffee, and he gave it to this. So there is no coffee. If anyone will plan to travel to India, I think you should take good coffee with you. And thank you.
Thank you so much for all the experiences, and it's very amazing to see, how we experience in different places and setups, different guidance, and I hope the next team can have also further good experience. So I will open the floor for a small discussion, and we go for dinner, and we can continue also discussion. So maybe I can give for Professor or Dr. Abel his friend, and we can start from there.
Thank you. forward in this venture. Dr. Beg, you have been instrumental. You have been pushing actually. So, and Prof, thank you for making this also a reality with short notice and also short period for this kind of collaboration. For the residents, I would like to congratulate you. I mean, this is what they have been telling me. You know, we have limitations in our setup. Not everything we do is like a state-of-the-art surgery or as best as we can do. There are things out there which, in the long run, we are planning like to adapt, but it's unfortunate that they are not here. But you need to know them and to see them at least by the time you are trained. So I think that's an eye-opening opportunity for you. How far neurosurgery can go. It's not always like putting the patient on table and operating everything. Starting from care management, planning surgeries, counseling patients, reporting hierarchy. You have seen how the processes are. Everyone is looking for someone who is really exemplary, and even life lessons and things that you have mentioned. So it's really fruitful. I think a fruitful collaboration in short period, and hopefully this will be also continuing in the coming years for the coming junior residents. And I again would like to thank Professor for the opportunity.
So I was extremely happy to see you out there, and in fact, when Dagi and myself had discussed a long time back about this plan, and it was only Dr. Dagi's idea of this observership, and he said, these are the people, they're the future of Africa, future of Ethiopia, and they need to be exposed so that they are ready when things change in Africa. So that is one. But I'm more happy that you took home the points of teamwork. Other than surgery. Surgery is if you got equipment, anyone of you can do it. If you have all these equipment, you all do the same things. Because if you have to do surgery at a particular speed, you need to be in a system. Only if you have a system will everything fall into place. Otherwise, just setting up your navigation is going to take hours to do. So the most important thing is you've learned that it is a teamwork, and that is what the take-home message in all of you. I think that is what I'm very happy about. Skill sets, surgery, everything is going to improve. There's no doubt. You have passion for the subject. You want to learn, and you want to do good for a patient. It's all going to come. Because if you want to do good for the patient, you are going to learn how to do well. You are going to learn how to operate a patient well. So the most important thing is patient care. We all, when we take notes in medicine, is to do patient care. Patient care comes first. All this is just to improve that and give a safe treatment, whatever. You should never make the patient worse than what they were. That is the most important thing that we all learn. So when we operate, we need to see them much better off than what they were. Unfortunately, another thing is, I'm so happy to offer you fellowships post-qualification. If you come, we have something called the Aster Academy. I think we need to discuss that. There's something called an Aster Academy, which gives out certificates. So we're going to make 3 months, 6 months, 1 year fellowships. Now we have fellowships from the university, which is only for Indians. But the Aster Academy, we can have people coming from anywhere in the world. And we will go through the legal details so that you can scrub and be part of the surgery and part of what you're doing. And if you have a complex patient, and a couple of them or 3 or 4 of see what is happening, you're most welcome. You can come with the patient and Dr. Dagi will make arrangements for you to come. So it's your patient, you're seeing what's happening. You will know what is happening, and then you will learn in the process how to do these things, how to learn these approaches and things like that. So you're most welcome to that. And I think from the talk, I understand how well you've gone through. I never imagined that you made photos and you put all this to a talk, which is excellent. I thought you're just there to see and you're happily seeing and going, but you're taking something more and some excellent thing, which I think is very appreciable from the team. And lastly, about the few things you showed us. One is the paper we use, the drape we use is extremely cheap because it's recyclable. If we use cloth, we used to use cloth, there's a lot of wastage of water. Water is a very, very important thing for us.
Yeah.
So that is why we use this. Those cups will go back and get recycled. So that's why if we use tumblers or things that has to be washed, they have to be washed and kept back. So there's a lot of water that is wasted. So to prevent water wastage, we do all these things. And it works out cheaper too for the patient because the laundry bills are very high these days. You know, when we send to laundry and we have a laundry outside, it's an outsourced thing. And the drapes, you know the drapes, huge drapes, they have to go for, and you can't compromise on the drape because whereas these things comes to rent, it is 150 rupees, 200 rupees, 300 rupees for a full sheet, 100 rupees. So it's extremely cheap as compared to using the drapes and healers and things like that. So that is why we use that, not yes. So I think I'm very happy, and we will continue this. It's going to be a continuous program, and I think with Dr. Dagi's vision and all of us working together, we should be able to do it every resident should be able to get one. And also, we will help in whatever way that is required. And the fellowship, definitely I'm going to talk so that you can come for 3 months, 4 months. See, small fellowships like spine fellowship, you can just learn the equipment, implants. Many of those people will do the implants there, and then you can do the surgery. So those things can be done. DBS and all may not be, but at some point, maybe 5 years from now, 6 years from now, you will be able to do it here. So you are future ready. That's what basically I think. If you are exposed, now you're getting a new microscope. Very soon you might get a navigation system. So you know already how it is used and where all it has to be used. So for you, it's going to be easier to implement these things because we learned the hard way. We never had any. So when we like 30 years back, when I started my neurosurgery, we never had all these things. CT scan was big at that point, and then we used to do angiograms for vascular shifts, and then there's an EDH or an SDH. Slowly from there, we were able to come here is because of constant change, and luckily for us, our whole medical system did well by acquiring things faster and faster. Having said that, I think thank you so much for those lovely talks, and I think I'm very happy now getting back and expecting all of you to come in due course.
You're already so grateful.
Thank you.
Thank you all for the nice, valuable comments, suggestions, and presentation. And also thank you for the 3 residents who have traveled on their tight schedule due to exams and already finishing up their residency. So I think we can continue the discussion on the tables. And now we can go for the dinner and refreshment. It is on the first floor, right? It is on the first floor. You are all invited. Please don't go before we are full. Okay. Thank you very much. Can we have a group picture?
Yeah, I think we should.
Yeah.